Maitland Concept, Assessment and Treatment Using Passive Movements. Everyone thought that when Jeffrey Maitland introduced the concept, already passive movements are existing. What is the big deal? Mobilizations, joint play techniques, John Mennel onwards, Galton, so many were using. So they were so not much interested in what he was trying to explain. Although passive movements include physiological movements and accessory movements, physiological movements are like flexion, extension, whereas accessory movements are glides, anterior glide, posterior glide in different directions. He was also from University of South Australia, Adelaide. Okay, Jeffrey Douglas Maitland. 2010 he expired. Okay. And over the years, the Maitland concept has become a benchmark that if someone knows the Maitland concept very well, they are the best manipulative physical therapist. So it has become such a huge standard or standard of measurement. Okay, and people nowadays accept that the Australian approach integrates mainly the Maitland concept throughout. Okay, so it's a very important concept, and it has withstood the science, the challenges of science, and also is established as one of the useful methods, safe methods for treating patients, because these are mobilization techniques which are oscillatory, and they are well under the voluntary control of the patient. And Maitland was open enough to tell you can use these techniques, however, you can use any techniques together with this as an adjunct. Most of the founders of the schools of thought have always described like their treatment is all in one. Okay, and that one concept is useful for all conditions, one for all. Okay, but he was very broad-minded to accept the fact that clinical presentation and spectrum will differ. Not all patients will improve, so you can always include any other therapies together with maybe electrotherapy, maybe exercise therapy. You can always include together with mobilization techniques. But what way he differed was the effectiveness of the technique does not lie in the skill of application of the technique. He explained that it is the thinking process behind the technique that is important. So the evaluation process is more in depth in order to understand what is actually the pathology. What is the steps or the principles of assessment in an usual clinical practice? But the modification what is done by Maitland is the 0.5, the reassessment. We do history taking that patient has more freedom to describe in his own words. Subjective examination, which is like we give options and we ask the patient which one it is. Is your pain constant or intermittent? Is your pain more in the morning or afternoon or evening or night? Do you have any sleep disturbances? Okay, which all activities aggravate your pain? Which all activities reduce the pain? We give a particular direction. That is called a subjective examination. Clinical reasoning. In the introductory lecture, I mentioned about Mark Jones. So, clinical reasoning model, hypothetico-deductive model, generating hypothesis, having multiple structures, multiple functional interactions in our mind. Okay, and it's like a computer software, so it can integrate and it can find when you put the search, immediately it will go searching everywhere and then it will try to give the answer. Similar to that, our brain also should have what is called as a clinical pattern. Okay, if this is the presentation, then what could all be the reason? If one reason is present, yes, then what could be the other reasons which should be there? If all are existing means what should be the problem? Everything we should have what is called as a engrams in our brain, and we can use it as a thinking process in order to decide the safety of the technique and the extent of the examination, how much we can examine the patient. Because most of the times manual therapy is the objective examination, some of the techniques itself are treatment. If you are giving a glide, glide is an assessment, glide is also a treatment. So, same way, patient also likely that they might worsen also if you don't know actually whether which direction glide and which grade of mobilization you have to give, which position the joint should be, okay, and whether the patient is really indicating that this is the treatment technique that is to be given. So it's very, very important that clinical reasoning comes before objective examination. After which you perform movement testing, palpation, and then other testing to rule out other structures for muscles, nerves, and then you decide the extent of the passive dysfunction. When you are assessing the passive movement or when you are assessing the glides, sometimes the patient's exact symptom will be reproduced. When that happens, that glide or a passive movement is a very important technique. So, when the patient tells the exact pain is reproduced, so that is the key technique which you should actually use it for treatment. But when you are using it, you should not use it straight away. You should know how in a graded manner you can progress and use the technique. And during assessment itself, the patient is telling you are giving an inferior glide to the shoulder. Patient is telling, yeah, my abduction is slightly better. You should reassess even after assessment itself. So you assess, reassess, you know that the direction of the technique, the particular technique is indicated. After that, you give the treatment. After treatment also again reassessment is there, and that reassessment is continuous even for 24 hours, 48 hours. Every subsequent session, the reassessment is always emphasized. We'll go into the details. History taking. All of us, we feel that we don't have time to listen to the patient. But we know that when we go as a patient, we always want freedom to talk. We want to feel that the therapist was having time to listen to me. And we also know that the therapist who listens to me is the best therapist. Okay? So there is no alternative that patient is always the central theme of the concept. It's very, very important that you should also show empathy. What is empathy is, the classical definition is putting yourself in another person's shoe. It means if a patient with low back pain comes, you should first think, if I am having low back pain, what all difficulties I will have. You should feel that. Then with that, then you should start interacting with the patient. And whenever you are asking questions, you should always ask in the history taking that, what is your problem? where does it pain? Okay, do you feel it is to do with only in the back or in the leg? Okay, if you give options, it becomes closed-ended questions. If you ask where all you have the pain, it becomes open-ended questions. Okay, so open-ended is the patient has the freedom to talk. Well, how much is the duration? What is the duration? That is open-ended. But if you ask, are you having pain for less than 3 months or more than 3 months? If you give options, it is closed-ended questions. History taking usually tries to examine the onset, the progression, the duration, the previous treatments, anything if it is taken, and associated experiences of the patient. So we should give time, we should give freedom for the patient to talk. It's very, very important, although it is clinically challenging. Subjective examination includes two components. One is body chart, where we mark the patient's symptoms, which area of the body the pain is present. We mark it as a on the diagram that is there in the next slide. And then we try to assess the severity, which is usually assessed by visual analog scale or a verbal rating scale, 0 to 10, 0 no pain, 10 maximum pain possible. And if you have a numerical pain rating scale, it gives the splits in terms of 2, 3, 4, 5, 6, 7, 8, 9. Okay. Visual analog scale and verbal rating scale do not have the split scale. You can measure the severity by any tools. Okay. And irritability. This is a term which nobody else described before Maitland. Okay. What is irritability? It's the tissue response. If a person sits for half an hour, he gets neck pain. He gets up, okay, he's not sitting, moving around, his neck pain reduces immediately. Or he's bending and reading, he's getting neck pain. Okay? And when he straightens the neck, immediately no pain. That means it is non-irritable. Another patient who bends and reads for just 2 minutes, he gets the neck pain, but when he straightens, the pain stays for half an hour. It means that highly irritable. So try to see the spectrum of patients who are highly irritable versus non-irritable. Non-irritable patients don't have pain when you return back from the provoking position. Bending forward brings the back pain. You come straight, no pain. That is non-irritable. At the same time, mild and moderate irritability are determined by the time duration. You are sitting for half an hour, then you get the pain. After that, it stays for half an hour, moderate. If you are sitting for 15 minutes, you get the pain. You get up, the pain stays only for 2 minutes or 3 minutes. Okay, mild irritability. So always irritability is another measure to indicate how much we can provoke the symptoms during examination. Patient with non-irritable symptoms, you can do full examination, because even if you perform the painful movement, when you return from the painful movement, patient will be pain-free. Nature is the intermittent, constant. Okay, sometimes the symptoms may be pain can be sharp, dull, okay, shooting, pulling. If it is nerve related, it can be tingling, numbness. Okay, that is the description of nature of the pain according to Maitland. He said that most important it is to do the assessment of the description according to the words of the patient. Okay, it's important. That's why nature of pain is another qualitative descriptor of pain. Okay, not the quantity. Okay, stability. Some symptoms will be worsening. Some symptoms will be improving. Some symptoms are as it is. All the three are stable. For example, last 3 months, the first month, that is 3 months before, I had pain only in the neck. 2 months before, I started developing pain in the arm also. Last month, I have pain in the forearm also. And now, today morning onwards, I am having pain in my hand also, sir. So, if this description comes, we know that it's stable and worsening. The next one is 3 months back, I had pain till the hand. Okay. 2 months before, I had pain only in the forearm. Last month, I had pain in the arm. And now I have pain only in the neck. If this description comes, we know that patient is stable and improving. Stable and unchanged or plateau. Very chronic patients are likely to be like that, where they describe, I have neck pain, only neck pain. How much? Visual log scale? 5 on 10. So how many days you are having? Last 1 month I am having. How it was in the beginning and how it is now. As it was, it is same. Okay. Any changes, anything, it is more, you have started feeling pain in the back or in the arm. No, it is only in the neck only, it is there. Okay. That is stable and unchanged. Unstable pathology is, sometimes patient will tell that it improved and then suddenly another time it worsened. Okay. Patient will not know what actually aggravated and what relieved the symptom. In that situation, it's an unstable pathology. Okay, it's a very careful marker for a clinician to note unstable symptoms. These are acronym together called as SINS, SINS, severity, irritability, nature, and stability. This is the body chart. You can see if a patient has pain, okay, in the right shoulder, we should mark the right shoulder. Yeah, like this. Either you can put a cross. The cross means that the right shoulder is abnormal. Okay. And then you ask the patient, do you have pain in the left shoulder? Patient tells no pain in the left. So you put a tick mark there. Okay. And then next, if patient tells pain is not just in the shoulder, sir, sometimes the pain comes to the arm also. Okay. So you can shade it if it is a diffuse pain. Okay, fully shade the arm. In some patients, they don't tell diffuse pain. Okay, so they might tell what is called as the pain which is radiating. If it is radiating pain, put the line with the arrow. And then next, there are other identifiers like, okay, if the patient tells sharp localized pain, okay, sharp localized pain, It's a thick, okay, thick shading. If it is a dull diffuse pain, okay, you can put dotted. Okay, more darker it is, more concentrated pain. So you can use different notations, and then you can also make sure that it should be marked. Okay, whatever you do, it should be marked. Don't be just mark it and leave it, because nobody will know what for you marked. Sometimes some people use some notation, another people use another notation. Okay, so that's why it's important that you label it also immediately. Besides that, if the patient has a past history, left knee problem, okay, then what you will do is left knee also you will mark it. Okay, so, and if problem was in the right shoulder, so other regions there is no problem at all, you put tick, tick, tick. You ask them also question, screening questions, these are called as. So hip also you tick, okay, knee you tick, okay. So if past history is present, then this should be marked and then said it's a surgery happened in the knee. Okay. All other regions should be marked with tick. Okay. So it's very important that you use diligently, and it's useful for inter-therapist communication. Okay. One therapist has marked the distribution of symptoms, other therapist can understand that and then appropriately apply the treatment. Okay. When you are applying the mobilization techniques, which factor determines the extent and the direction of the physical examination is the irritability. So we saw in the description that the time duration for provoking of the symptom, okay, that is this, and time duration for relapse of symptoms. So irritability is a measure of the longer the time it takes to go off, it means that highly irritable. Shorter time the symptoms go back, it is mild irritable. Immediately if the symptoms returns to zero, non-irritable. Okay? So that way graphically irritability can be understood. And what are the assessment markers which you have to do whenever you are examining a passive movement or a glide? Maitland explained it as joint signs, or also which include pain, which is like what is, when is the pain come? When you are doing a flexion of elbow, okay, at which position the onset the pain comes? The first pain, okay, initial pain, okay, and then the final or the maximum pain, okay, because during the movement sometimes the pain keeps on increasing, you will be moving it to 15-30 degrees like that. After that the pain will become severe, patient will tell please stop, that is maximal. Final pain is, range itself is limited, so at that position how much ever the pain is, that is final pain. Resistance is the tissue stiffness. Pain is reported by the patient, resistance is assessed by the therapist. Muscle spasm occurs as a protective response. If the injury or inflammation is more severe, patient couldn't allow the movement. And then we document these joint signs, okay, pain, resistance, muscle spasm, by use of what is called as movement diagrams. Okay, we see the movement diagram. Okay, there is a notation for the range of motion. Okay, normal limit of the range of motion. If it's beyond the normal limit, it's called as hypermobility. Before the normal limit, it's called as abnormal limit of the ROM. And during that, the intensity of pain, resistance, and spasm can be marked in the y-axis. X-axis denotes the range of motion, okay, and y-axis denotes the intensity of pain, resistance, and muscle spasm. Initial pain is called as P1, okay, P1, and the final pain is called as the P prime, okay, it's like P dash, the maximum, what is that range of motion at that. And initial resistance is called as R1 and then R prime. S1 is the spasm onset and S prime is the final, how much the more the spasm came. So usually the normal movement as you are moving the elbow, okay, it will be, you are going like this, okay, there will not be anything. Then you started feeling it is stiff and that stiffness increases. After that pain starts. Then after that spasm comes. Okay. So this is one kind of a presentation where resistance comes first. It means that joint is stiff. Okay. And this patient may be given mobilization easily. But if someone is having spasm first, then definitely it is very difficult and we should be very, very gentle when we are using the, okay. If the spasm comes here, that means it is protective. You can't push through spasm. Okay. Pain comes there also first. You should be reducing the grade of the mobilization. Okay. And one therapist has marked it in the movement diagram. Another therapist can see it and understand what is the primary movement testing, what is the behavior of the joint. Okay. So that way, this is a very useful inter-therapist communication tool. Example of a stiff joint, hypomobile joint. Okay. You can see the resistance starts first and then keeps increasing. Okay. Okay. Resistance starts first and then increases, but it is not the one which is limiting the movement. Okay. Pain starts later after the resistance. So you start feeling the joint is stiff. After that pain starts, but the pain only increases to stop the movement. Okay. You can know from here that pain is limiting the range of motion more than the stiffness, more than the spasm. Okay. So this patient's pain relief using graded mobilizations, which is mild oscillatory, initial graded, like grades 1 and 2. So you can see that after that progression of the range of motion can be done. Okay. Hypermobile, always the range will be excessive. Okay. Here again you can see a similar picture where in the extra range of motion, sometimes resistance will start first. After that only pain will come. Okay. And spasm will come last because in order to prevent the joint from dislocating. Okay. So whenever you are giving glide, you should be very careful. It's a precaution that hypermobile joints should not be over treated. Okay. After you understand that the responses of the joint. Then you try to see which is the technique which actually reproduce the patient's symptom. After that, you recheck with the patient 3 factors. One is subjective, objective, and functional. If I am giving inferior glide, after that I should ask the patient, how is your shoulder pain? If the patient tells my pain is less, subjectively is better. I should check the shoulder abduction, the range of motion. If the abduction range was 70 degree before assessment of the inferior glide, but after assessing the inferior glide itself, is getting 90 degree. That means objective reassessment, patient is showing positive signs. Functional, if the patient was not able to reach the neck, not able to reach the head, okay, functional improvement comes after an assessment. It means the third asterisk. Asterisk means important marker. So use the term asterisk for 3 asterisks: subjective, objective, and functional. So if a patient tells I am having pain on squatting, you should reassess the pain intensity, that is subjective, the knee range of motion, that is objective, and squatting you should recheck, that is functional. Okay. So this has got very important implication that you are concentrating on the patient also, at the same time you are doing your assessment also, and the functional limitation what the patient had also you are focusing. So you should always reassess during the session, which is during the physical examination, after the physical examination. Okay. After the session, you should check it for seeing the effect of intervention or the treatment. After 24 hours, it is the homeostatic response, because glide also is a new thing, external force that is given. So body, how it is responding to treatment, you can know only after 24 hours. So it's an ongoing reassessment. Grades of mobilization. If the pain is coming first during the movement diagram or movement testing, grades 1 and 2 are applicable. If stiffness resistance group is the patient is there, grade 3 and 4 can be used. In the spasm group, grade 1 will not have any effect, but grade 2, but irregular rhythm. Okay, you don't give it very fast, you don't give it very slow. Okay, you keep alternating and don't give uniform rhythm. Spasm will always set in. So staccato rhythm it is called as. Grades of mobilization, 4 grades. You can see small amplitude, okay. Small amplitude, okay, oscillatory movement, which is done at the beginning of the range. Okay, so you give like this, that is grade 1. Large amplitude oscillatory movements performed at the beginning of the range, that is grade 2. And then you have large amplitude oscillatory movements to the end of to the resistance. Okay, that is grade 3. Okay, so it goes to the resistance. And the grade 4, it comes from very small amplitude into the resistance. Okay, so grade 1 and 4 are small amplitude, grade 2 and 3 are large amplitude, but 2 is beginning of the range, 3 is to the resistance. Okay, so grade 1 and 2 are given for pain patients, and grade 3 and 4 are for resistance patients. And for spasm, it was grade 2 with staccato rhythm. Mobilization techniques, they are all there for various regions. Okay,